Thanks so much for coming. Thanks for the wave. So I'm Kelly Watson. I am the Vice President and Chief Nursing Officer here at Rutland Regional Medical Center. I've been here since July, so I guess going on 8 months now. Some days it feels like I just got here, and other days I feel like I've been here forever and ever, which is a great thing. It's been wonderful to be here. So this is our first forum of 2023. From what I understand, it's been a couple of years since we've had one of these. So bear with us. We're still kind of working through the kinks of getting these back up and running. Some of the communication going out, how we're going to advertise them in the future, we kind of learned from this go around. I do want to thank everybody that participated in the pre-forum survey. Thank you so much. We had a lot of responses. It was a good response rate from folks. We really took everybody's questions, their topics that they wanted to hear about, and we have tried to work that into every part of the presentation today. So if we missed anything, or if there are additional questions, we are going to have a Q&A sesh at the end of this. But if we don't get to everybody, don't worry. We will be sending out an electronic evaluation form following the survey. We want your feedback. We want to know what you thought of today. Are there different topics you want to hear about? What was great? What did we totally miss the mark on? But then also use that form to ask questions that maybe didn't get answered today. I really encourage you, it won't be mandatory, but I encourage you to put your name, or at the very least your department, on the form if you have a question, because it's very, very important to us that we get back to everybody. I may not know the answer, but we will find somebody who does. So I want to make sure that we do get to everybody's questions. So again, please use the post-forum form. And if any of your teammates don't make it here today, they're still going to receive the form. So encourage them to fill it out too, because we're going to use it to build our next forum. We're going to try to do these 3 times a year, but at a minimum twice a year. And the reason for that is because we're also getting, from an organizational standpoint, our town halls back up and running. So those are going to be every quarter. So a lot of what we cover in that, workplace safety, recruitment and retention, some of our facility design updates, that's all going to be in those town hall meetings. And so we want to make sure that this isn't too much duplicate information. So that's that. We are recording, so I ask that you maybe silence your cell phones or turn them down. If you do need to have a conversation with somebody, please step outside so that we can try to get the audio as best we can for this. All right, where am I? Well, let's get started. So I'm going to start out with kind of a high-level overview of our strategic priorities, our nursing strategic priorities. Our strategic plan is still somewhat evolving, but our strategic priorities are pretty clear. So I'm going to talk about those. I have about 6 or 7 slides that I want to go through. Again, it's going to be mostly high-level, nothing in really like specific detail. Then we're also going to hear from a variety of our outpatient leaders. We really want to hear about all of the nursing events and activities that are taking place in our outpatient areas. So we have a few of those leaders here today, really trying to make this an organizational-wide nursing forum and not just focus on an inpatient side or outpatient side, but really all of us. We're also going to hear from our shared governance nurse leaders, hear what's going on there, make a pitch for people who want to be involved in that committee. So excited about that. And then we'll wrap up with Gert Mays, our new manager for Nursing Excellence. She's going to talk to us about the Magnet program and some updates to the CAP program. So, and then we'll open for Q&A. So, all right. As we come out of this global pandemic, we're really wanting to look at our bright future. I really think that this is something we need to keep top of mind because, as you all know, during COVID, a lot of things stopped. our priorities shifted. Committees that we used to have and get together, activities that we used to participate in, those things stopped. When the pandemic started, I was practicing in California. It was pretty chaotic, and we experienced the same things there. Shared governance stopped. A lot of our committees, a lot of the things that we used to just really focus on, they weren't the priority anymore. I'm really optimistic that as we come out of this pandemic, we really do have a bright future. I think we're coming out of it smarter. I think we're coming out of it stronger. And I'm really, really optimistic that we have this opportunity to kind of redefine our nursing practice. How do we come up with innovative ways to address nursing shortages? How do we come up with innovative ways to address the fact that our patients are sicker? And oftentimes we're seeing they have more behavioral health needs. We can do this. So these needs are really what are shaping our priorities. We have to prioritize workforce development, and that's largely with recruitment and retention. We have to prioritize quality and safety. And that's not just with our patients, but that's with our workforce, which of course bleeds in to recruitment and retention. And all of that spills into our ability to be financially sustainable. And so it was very purposeful that we put these strategic priorities in a circle, because there isn't really one that's maybe more of a priority than another. They're all a priority, and they all overlap, and they all connect. And so I think it's really important that we look at that. So again, these priorities, they really span across our entire organization for all of us as a nursing body. These are all priorities in the outpatient clinics, they're priorities in the inpatient world, but our tactics and how we address them, of course, are going to differ depending on where we are. Elizabeth maybe has different things that she's tackling with recruitment or retention in her areas, whereas Wendy and Sam are battling a whole different thing with recruitment and retention on an inpatient nursing unit. So again, while our tactics might differ, our overall priorities are the same. So, what's driving our strategic priorities? Well, I just shared some of it, but it's also data. So, data. Data is really what needs to be driving our decisions. We need to look at this data, we need to prioritize what's the most important, and we need to use this data to come up with our action plans for how we're going to address things that need improvement and how we're going to maintain things that we're doing really well with. So I wanted to share this with you. This is a snippet of our scorecard. Of course, I wasn't here, but I believe several years ago we had a scorecard that we routinely shared and posted in different areas of the hospital. And like all the things we just talked about, it kind of fell to the wayside. We got away from sharing this data. And so over the last several months, there's been several of us, teams of people really, who've come together to get this back out and in front of our teams. This is just the top portion. There are 3 slides of the scorecard, but they couldn't all fit on one slide, so I broke them up. But as you can see, this scorecard is really highlighting the areas across our entire organization where we really need to focus. When we look at access to care, I think this is a really perfect example of how some of our metrics are very specific to inpatient, like inpatient length of stay, but then they're also specific in some ways to our clinics when we talk about being able to get seen within a month. But where we have shared metrics, and I think this is a good example, like I said, is our readmissions. Our readmissions is really the responsibility of all of us. It doesn't matter where we are, because this is really reflecting how we take care of our patients across that whole care continuum. And this is where we need to demonstrate an ability to communicate with one another. We need to understand our nursing practice in all of the different areas so we know how our care delivery is impacting the next person. Of course, resulting in our patients having the best possible outcome and experience. And then the tail end of our scorecard is as you can see here, some of our workforce metrics. And again, workforce being a top strategy for us right now. Really needing to focus on this. We need to be looking at this data frequently. We need to understand it. We need to know specifics. For example, with our voluntary FTE reduction, these are employees who aren't necessarily leaving Rutland Regional Medical Center. They're staying, but they're significantly reducing the number of hours that they commit to working. We need to know why. So we're very, very close, I believe within a few weeks, of implementing a third-party vendor who's going to help us conduct exit interviews. And those exit interviews are not just for people who leave the organization, but they're people who fall into that category with the FTE reduction, so we can get a better understanding of why. Because without that data, we can't make decisions about what we're going to do about it. So I'm very optimistic that we're moving in the right direction and that these things are going to really help us move not just our nursing practice, but our organization forward. All right, let's go back to our priorities. Workforce development. There's the recruitment section. Let me just jump ahead real quick. While there are only 2 bullets, this does not reflect the numerous things that we are doing to address recruitment. We could have an entire forum just on recruitment. I think the VP of HR, Brian Kurds, and I, Molly, who I see in the back, we meet, I don't know, would you say multiple times a week to talk about retention. So again, today for this forum, I'm just going to be talking about a couple key points, but I don't want you to think that these are the only 2 things that we're doing to address it. So we'll go back up to the top here with leadership development. Leadership is really key to us being able to address recruitment and retention. We need our leaders who are motivating our teams. They're modeling that positive behavior. They're supporting our teams. They're acting as advocates on behalf of our teams. They're elevating concerns up the chain so that we can address it from an organizational standpoint. It's really important for us to have strong leaders in place. And it's really important for our leaders who are in place to feel like they're supported and given the tools to be able to lead their teams effectively. And this isn't just managers and directors or myself as a CNO. This is charge nurses, preceptors, our clinical education team. This is all of us, right? And so a huge focus on leadership development so that we can use that to address some of our recruitment and retention issues. I do want to call out a couple of new people. We do have some new leaders to the organization. We have Wendy Klein back here. You want to give a little wave. Wendy Klein, our new director for the 5th floor. We have Allison Windus. She came on board in January as a quality consultant for us, but as of next week, she's going to be taking over for Kathy Boyd as the interim director for quality and safety. We have Liza Eddy here. She's also new to the organization. She's our new patient safety manager in quality and safety. So I apologize. Did I miss anybody? Okay. But we're very excited to have new leaders here. We're filling some key leadership positions, and it's really exciting. Mentorship, also important. We really want to look at our new grads. Our new grads, as we've seen, their first year turnover is a little bit higher than we want it to be. And so we're really working hard with our training and education team, our nursing excellence team, which is a party of Gert. We are really trying to look at how we can create a formal mentorship program for our new grads. Ideally, this program would last 2 years because we really want to support folks not just while they're in orientation, but when they come off orientation. And how do we make sure that we're getting feedback about how we've done during their onboarding? What challenges are they having? Do they have a safe place to maybe vent, which, let's face it, we all need that safe space to do sometime. So setting up those formal mentorship programs are going to be really important for us. We're also going to hear from Gert later today about some changes with the clinical advancement program and how we can better support and provide better mentorship for our nurses who are going through that program so that when they're doing their projects and they're looking at research and they're looking at ways that we can implement performance improvement on the units, that they feel supported and they have that mentorship. So mentorship is a big part of our workforce development. And then recruitment. Oh gosh, recruitment. Like I said, we could talk about recruitment all day. I think some major takeaways is that we have a huge effort going into increasing our social media presence. Really trying to look at how we utilize places like platforms like LinkedIn. We're also looking to re-engage with our international staffing firms. And of course, kind of the biggest one is leveraging our partnerships with academic institutions and really looking at the new grad pool that we have right here in Vermont, because quite honestly, that is our biggest pipeline in terms of getting nurses into our hospital, or into our organization rather. Those relationships with our academic partners are absolutely critical. We need to be creating a positive environment that is conducive to those students learning when they're here, but we also need to be providing feedback to our academic partners for how they can better prepare their students so that when they are here, they're getting the most out of it. So it's really a two-way connection there. It's a two-way partnership. It's not just us supporting the clinical rotations, but it's us also providing feedback so they can be really effective. There's also a handful of us who are serving as faculty at some of the local academic institutions. I believe we have a few people who are part-time faculty with VTC. We have some people who are part-time faculty with Castleton. I myself recently joined the faculty at Castleton in their master's program. So for anybody who's really interested in getting more engaged with our academic partners, please let your leader know. Let the education team know, because we'd love to get you involved. We're all part of this. And so if anybody has that interest, please send me a note. We're also working really hard to participate in on-site events. Molly does an amazing job. I keep pointing because she's in the back of the room. Molly does an amazing job with really connecting us with opportunities to get in front of people on those campuses. So we're going to be setting up, I think, at Castleton and VTC? Norwich next week. We're also looking with folks around the state who are working with high school students who are expressing interest in entering into the healthcare profession. And so next month, there are a few of us who are going to be presenting. I think Lisa, Debbie Huff, Sheena Fisher, who's not here today. We're going to be going over to Castleton and presenting what our services look like to 11th and 12th grade students from all over the state. So really trying to engage within our community to recruit more folks to come here. Other tactics for recruitment, of course, are our sign-on bonuses that we try to offer, and doing ongoing assessments. Excuse me, a little dry. I should have brought some water. See, we're learning. Next time I'll bring water. But we're really trying to make sure that we do ongoing assessments to make sure that we offer a competitive wage and that we're competitive within the market. So like I said, I could talk all day about recruitment, but those are kind of the main points. And then engagement and retention. My viewpoint on this is that this is probably the biggest part of the whole shebang. This is what we really need to lean into. Being engaged, wanting to be part of the team, wanting to be part of the solution. This is what we need. We need to create this positive culture that people just want to be here and want to be involved. And again, a lot of that kind of went away with COVID. We weren't allowed to get together. We all had to be remote. I think we really kind of took a hit, not just as people, as individuals, but I think as a nursing profession as well. And so I'm really, really excited that we're doing what we're doing right now, getting together, talking again. I'm so excited about the shared governance slide that you guys are going to see, about the work that they want to do. We want to get more people involved in that. That engagement is absolutely key. Leader rounding. Some of us are already doing a great job of leader rounding, and some of us we need to work at it. We need to be a little bit more mindful and purposeful with it, really making sure that all of our shifts are getting time with us. If we're not able to come in maybe on those shifts, making sure that we're engaging with those team members so that they're being included in some of the committees and groups that we have going on. So rounding is a big thing. But we also want to make sure that we encourage folks that when we are rounding, that they're giving us feedback. That's the time to be sharing ideas for what we may want to implement. Again, things that are going not so great, but we also want to share what's going really well, because there's a lot of great stuff going on out there. Hold on one second. Oh, that was just perfect. Okay. So we also want to start celebrating excellence, recognizing excellence. I think we have a habit, myself included, of kind of fixating on the things we need to fix. We're nurses. We want to make it better. So we look for what's wrong and how can we fix it. But I do think that we need to make a conscious effort to really hone in on the things that we're doing really, really well and make sure that we're talking about it, because there's so much for us to be proud of. We want to get our DAISY Award program back up front and center. So you're going to be getting more information about that coming up soon. Gert and I were just talking last week about something called a PEDAL Award. The PEDAL Award being an award for excellence for non-nursing clinical staff, to make sure that they're rewarded, because they're our partners. They're right there along with us. These are our LNAs. These are our techs, our psych techs. And they deserve to be recognized just as much as the rest of us. So really excited about some of these recognition programs. Shared governance, you'll hear more on that later. I already talked a little bit about the exit interviews. So again, a lot of work going in to engagement, and a lot going in to wanting to understand how we can retain our staff. One last thing on engagement, I did have a comment in the post forum survey where somebody asked, I can't remember if it was a comment or a question, but the idea was, how do I get in front of leadership and feel like I have a voice? And I just think that that's such a great, great question. There are so many ways to do this. During rounding, please talk to your leaders, whether it's me or someone else from the executive team or your leadership team on your units. We also have committees that people can volunteer for. Our Diversity, Equity, and Inclusion Committee is a great one. Our board president, Mark Foley, sits on that committee. We have numerous executive team members who sit on that committee, as well as a large representation of frontline staff. That is a perfect example of how you can get involved. You can be front and center in front of our board president, sharing your ideas, sharing your feedback. These are the ways that we can get involved and have our voices heard. So I strongly encourage you to look for those opportunities, seek them out, ask about them. I know HR can help provide opportunities for committees to participate in, training and education, your nursing leaders. Again, if we don't know the answer, we'll go find somebody who does. So those are really great ways to get involved. Shared governance is another one. The last couple shared governances that I went to, there's all kinds of visitors in those meetings. We have Mitch Baruti, our chief compliance officer, who goes. Several of our senior nursing directors are there. We have a variety of people who are there, and that's a great opportunity to get involved and be able to have your voice heard. I think that's one of the benefits of working in a community hospital, is that we do have that ability to get front and center in front of leaders and share what we're thinking. So I just wanted to make sure that we touched on that. All right. Along with retention, of course, is workplace safety. I can take absolutely no credit for the top part of this slide. I 100% stole this from our Vice President, Brian Kearns, and as well from Mitch Baruti and from Roger Wakeman. These are their overlapping focus areas that they presented to our board a couple of weeks ago. Really focusing on workplace violence prevention, organizational security, and occupational safety. Addressing patient on staff violence is a top priority. not just in this organization, but within the community, within the state, and at a federal level. I think I'm on a CNO call with all the CNOs in the state of Vermont twice a month, and I can tell you that this is the main topic on every single agenda when we get together, is how do we address workplace violence? So a lot of work is going into this. Again, this is another topic that we could just set up a whole forum just to talk about this, so I will keep it a little high level at the moment. We are currently assessing the need for additional hold and restraint training. That's ongoing work right now with a couple of our nursing leaders along with our safety and security team. So I'm excited to hear more information about that. We're also conducting code gray drills. These pictures that I shared were from yesterday. I don't know how many people were here yesterday, but did you hear the overhead code gray in the ED drill? I immediately ran because I couldn't wait to see all the action. The ED team you guys did a phenomenal job. The staff, the nurses, the psych techs, the security officers, our actor, who is our fake patient?
I can't remember his last name, but
Chris. Okay. He was amazing. He was great. I feel like daytime Emmy nomination, 100%.
Said I would like to help with the drills.
Oh, he was a natural. Yeah, he was a natural. But it was really encouraging to see this multidisciplinary approach to how we can improve how we protect ourselves and our patients. And I think that's something that was so remarkable about what I witnessed yesterday with this drill, was that yes, this was about how we can protect ourselves, make sure we're not putting ourselves too close to a flying foot or an arm, but it was also to make sure that the restraints that were applied were done so in a way that would not cause a pressure injury on the patient down the road. And so it was just very remarkable to see the level of engagement in this drill. And I think that we need to keep doing things like this so that we can identify, again, what we're doing really well and identify the areas where we maybe need a little bit more education or training. So I didn't ask anybody's permission before I took their picture. I'm sorry, but hopefully they're not upset. They all looked great, and they were all amazing. So physical security. We've implemented 30 additional security cameras, in our plant. That's both inside, but also in some of the parking lot areas. We've added additional security officers to our team with increased presence in our ED, our clinics, and at points of entry. I know that Roger Wakeman and his team, his security team, are truly committed to keeping our employees safe. They also meet what seems like 500 times a week to talk about ways that we can enhance our workplace safety. So really proud to be part of that, and you will definitely be hearing more about that in town halls, as well as the workplace safety committee meetings. I think Ziggy from the ED is a participant in that committee meeting, as is Christy from SCU. So great nursing representation on that committee. Again, that's another way where if people are looking to get involved, reach out and see how you can be participating in that so that we can be part of the solution of addressing this very horrible issue. I'll go ahead and move to wins. I moved over something. Occupational safety. We just conducted a gap analysis of workplace hazards, and we're identifying where we can enhance compliant and best practices, so we're putting together action plans to address all of those. Really great work. And then I'll finish up with a couple of workplace safety wins. The implementation of the DASA tool, which was implemented in the ED in December. That's where we piloted it. For those of you who aren't familiar, DASA stands for Dynamic Appraisal of Situational Aggression. I have to write it down because it doesn't matter how many times I see it, I can never remember the entire acronym. But DASA, as it is called, is a tool that we can use for specific populations of patients where it can help us identify whether or not they might be more at risk of engaging in a violent act over what's the period of time? Is it the next 24 hours?
It is, right there. Yeah, every 24 hours.
Every 24 hours. And so we implemented this, as I said, in December in the ED. Flavia, our ED educator, was amazing in giving me a quick update this week. And she shared that communication has improved between our nursing staff and the psych techs. Now that we have this tool, we have a better way to communicate to the staff who are maybe sitting with one-to-one patients. But she also shared that post-go live, as expected, we have a couple limitations with the tool. And so this is a major topic at our workplace violence committee meetings. We're working through some of those limitations to see how we might be able to improve it. And we're also putting together a work plan for how we can implement that in other areas of the organization. So stay tuned on that. And then we're also actively engaged in local and state legislation to recommend language to several statutes to improve our response efforts against violence. Our ED medical director, Dr. Allison Davis, she has been absolutely front and center with state lawmakers about what we can do to put in place to protect healthcare workers from violent patients and violent visitors. She and I had an opportunity to go up to Montpelier a couple weeks ago now. We had breakfast with some legislators and talked about how we can get support for laws passed that would support violent people being removed from our facility should they engage in violent behavior with a healthcare worker. So a lot of work going on behind the scenes with this. All right. It's my last slide, I promise. Then I'll turn it over. So going back to our strategic priorities, of course, quality and safety is one of our other major priorities. Data management, I mentioned at the very beginning, I showed the scorecard. I know I didn't go through all of the metrics, but I really just wanted people to be familiar, see it. It's going to be out there. We're very close to having it live and in every department. I encourage you to look at it, ask questions, ask your leaders, if you don't understand one of the metrics. Again, if they don't know, they'll find somebody who does. We will hunt the quality team down. And you'll see our quality team rounding frequently. And that's a great opportunity to grab them and ask them about some of our quality metrics as well. And maybe if you have great ideas for how we might be able to address something, share it with them so that they can bring it back to our team and maybe we could implement it house-wide. I also want to mention that several of our NDNQI data is represented in the scorecard. We're also looking at how we can do a much better job of getting that information out and routinely communicating it with everybody. Doing a lot of work with developing a roadmap for data governance. This is truly a team of people. Data analytics, quality and safety, Dr. Todd Gregory, myself, nursing leaders, we really want to get a better handle on our data. Where is it coming from? Who is in charge of gathering it? Who receives it? How often do we receive it? What is a regulatory requirement that we report it out? How frequently are we doing that? There's a lot that goes into this. And so there's a lot of work going on right now to get that all organized, and that will help us be able to communicate it much more effectively and efficiently with you all. So really encouraged about that. I definitely see that as a bright future initiative. So excited about that. And then the last thing I'll mention, and then I'm actually going to turn it over to Allison Windus to wrap up the quality section, is event reporting through our radar system. We rolled out radar, how long ago did we roll out radar? Somebody help me out with this. 2 years ago? Almost 2 years ago. And like anything new that we roll out, there's going to be kinks that we need to work through. There's going to be some challenges. And so we've identified some of those. And so again, a team of people working really diligently to put together a policy that will help guide us, hold us accountable, and by us, I mean leadership, in how we address those event reports, how we communicate back, the timeline of when we communicate back. It's incredibly important. And our employee engagement survey results from last year told us just how important it is. So I'm really, again, very optimistic that we're moving in such a positive direction to really identify where we have some gaps and work together as a team to figure it out. So excited about that. All right, I am going to pause here and let Allison kind of take it away. I do want to note, Kathy Boyd, our senior director, she has been the interim quality director for the last 9 months. She has been absolutely phenomenal. She is so passionate about healthcare quality and her teams and making sure that she's serving this organization to the best of her ability. She has been doing a tremendous amount of work to move some initiatives forward, particularly with falls and pressure injuries, along with SAM2 and a whole group of people. I could mention everybody. But she was supposed to be here today to be able to talk about her great work that she's helped lead, but she unfortunately had to leave early, so she is not here to present that. But I do believe that it's important that we recognize that she has really played a tremendous role in supporting our quality team as we continue to search for a permanent leader. But with that said, I'll pass it over to Allison, who's taking over as the interim quality leader, and then we'll get into the rest of our presentation.
Oh, I don't need
you don't need that.
I only have a slide.
Okay, I'll just stand here. I'll stand here.
Actually, I only have 4 bullet points of a slide. You just stay here.
Take it away.
So, hi everybody, how are you? I am Allison Winnes. I've been here since January 16th. I'm very excited to be here. Been working with a great group of people in quality and patient safety. And I am kind of pinch hitting for Kathy because really these are the initiatives that she got off the ground, and they are successful in large part due to her leadership and also the leadership and the engagement of the quality team, and in turn the engagement of all of you guys on the units who have been doing this. We do have a falls committee. This is also one of our organizational scorecard initiatives, and we have been making great strides on that right now at the moment under the leadership of Karen DeNicola, who is one of our quality and patient safety improvement RNs. Karen is also a Floridian like I am, and Karen has been here since December. So she's walked in as the quality improvement specialist for this initiative, and now with Wendy Klein as the nurse clinical leader, and we are looking for a physician leader to join us in this initiative. They're making great strides. We have built a bundle. We're starting to work toward bundle compliance. We have a lot of things that are being put in place for that. We have, and Karen can stand up and spout numbers for us if you want, but while we're still seeing, high numbers of falls, and I'm going to be honest with you guys, there are 2 things I've always believed about falls. First of all, there is no good fall risk assessment scale, and I've said this to some of y'all already. Because if there was one really good one, that's the one all of us across the country would use, and the fact that we have 45 of them means that there's probably not one gold standard. However, and like I always say, nurse thinks the patient is going to fall is probably as good a risk assessment as any of the scales you're going to use, right? And second of all, patients are going to fall. No matter what we do, unless we suspend them from the ceiling, they are going to fall. And so what are the things that we can put in place to constantly remind them, make sure that you call, every time we leave that room. Okay, we're agreeing that you're going to call. You're going to use that call bell so you don't fall. And some of the other things that, you guys have put in place into the bundle compliance. So we're still seeing falls. And we're going to see falls. We want to cut that number down, obviously, but the really good takeaway from this is by the efforts of all of the staff at the bedside, and I know it gets really discouraging when you do have a fall, but remember, we have cut down the number of falls with injury hugely since we started putting this bundle in place in December. So I know, especially in some areas that see the higher numbers of falls based on the types of patients that they deal with, sometimes it can feel really discouraging. But there's progress being made, so it's really exciting. Pressure injuries has been a wonderful project that Sam Holinsky has been running and done a beautiful job, and now our new patient safety manager, Liza Eddy, has stepped in to partner with her on that. I think we are moving toward also doing a clinical nurse leader who will be a champion for that, along with the physician leader. We're trying to build that dyad leader relationship into all of our big initiatives. And so we're making great headway on that. And it's not just a turn day. It's not just a flip day. There is a big initiative coming up where this team and everybody else who wants to volunteer. So we are looking at every single bed in this organization and every single mattress in this organization. I mean, there's a huge amount of work going on to prevent pressure injuries for our patients. Health equity, we are partnering with the Vermont Program for Quality in Healthcare Collaborative or something like that. So yes, so we are doing this with every hospital in Vermont. We are looking at our health equity programs, how we address health equity, how we collect data on all of the different elements of diversity, equity, inclusion. And so that's going to be a big thing. The other thing is it's also a CMS requirement. And we have Joint Commission, who is our deemed body for CMS. We're waiting for them to come in, but this is actually important and exciting work. We have things that we are marching out for this year, and then we will be rolling it out through a 3 to 5 year plan. At the end of this plan, what we'd like to be able to do is start addressing some of these gaps in healthcare that we see with certain populations. And so it's a pretty exciting initiative. And then the fourth one that we have up here is the quality and safety platform. And this is everything that Kelly just said. We're looking at data management because right now we've got all of these different databases and applications. Everybody wants data, and you want data that's specific to the work that you're doing. You don't just need to see how the hospital's doing. You need to see how you're doing in your area and what your opportunities are, and we're working on that. You also want to be able to see that in a timely manner. I don't want to see 90-day-old data. It means nothing, right? I want to see something that was yesterday or last week or even last shift, right? So if we can streamline, and the quality team is working with Laura Galster's team. They're just fabulous. We've got a couple of other stakeholders pulled into this, in addition to a lot of leadership support. If we can streamline that and really get our data down and provide the data that we're being asked for, the other part of it is I have a really talented quality and patient safety department who spends a lot of what I call non-value added time doing a lot of manual data massage. And who is it who keeps laughing at me about data massaging? Nancy, I think it is, because I keep using that term. So if we can free them up from doing that and make it more streamlined for them, that gives them more time to come and be partners with you, because our vision for the quality and patient safety department is really that they are on the floors, they're supporting you, they're partnering with you. One of the things in your patient engagement survey is I don't really see or I don't really know what the quality improvement activities of my hospital are, and Rutland Regional scored kind of marginally on that, kind of solidly mediocre on that. And we want to change that because there is a lot going on and we have to be much more visible about it. So that's part of the quality and patient safety platform. It includes looking at radar. It includes optimizing the staff. It includes things like our committee structure and how we do quality improvement activities. It includes policy and procedures, how we do a formalized structure around there, and a whole laundry list of other things. And all of this, you see this wonderful QAPI plan up there. We are required by CMS to prove how we handle quality, how we handle our metrics, how we address patient safety and what we do about it, and how we evaluate it. And we're also required to set goals. So these 4 things right here are the 2023 goals. They're not the only projects we're working on, but these are the 2023 goals. And at the end of this year, we'll go back and we'll evaluate how well we did on them, because they all have metrics that are associated with them. We'll see how well we did on them. We'll be reporting that out to everybody too. This is no longer just a thing that sits in quality or sits in senior leadership. This is a house-wide endeavor. So I took up a lot of time for 4 bullet points. So does anyone have any questions for me? All right, thank you.
Thank you so much. All right, so we'll move right along. Again, just wrapping up with our strategic priorities. It's workforce, it's quality and safety, and it's setting ourselves up to be financially sustainable. So you're going to be hearing a lot more about them. And again, my commitment is that we do a much better job of getting the data out to you all so that you know what it is. And I really encourage people, get involved, join some committees, let us know your ideas when we're rounding, so that we can all be part of those solutions. Okay, we'll move right along. I think, Lindsay, you're up. Is that right?
Oh, yes.
Okay, so a few of our outpatient sites are just going to give a kind of brief overviews of what they're doing and what they have going on. So take it away.
All right.
Take it away, Russ.
So hello, my name is Lindsay Munger. I am the director of the Foley Cancer Center and most recently DI Nursing and Infusion Services. So,
sorry.
click the button for me. Thank you. So I figured I'd start with DI Nursing. It is new to me, and this past week I've actually started to jump in to understand the roles and what happens in DI Nursing on a regular basis. So I thought this would be a great opportunity to kind of just touch on the different services that's provided in DI Nursing, because it's a lot more than I realize that they do on a regular basis. There's about 10 nurses that work in DI Nursing on a regular basis. We are open from 8 to 5, Monday through Friday, and then on the weekends, Saturday and Sundays, 8 to 12, where they give IV antibiotics. So cardiology procedures, this is they assist cardiologists with cardioversions, transesophageal echocardiograms, link insertions, pacemaker and ICD insertion and generator changes. And they also do help with dobutamine stress tests. Dr. Wingett comes down from UVM once a month and provides services here, battery changes and whatnot. Infusion services, this one I'm a little bit more familiar with from being in the cancer center also, but this is outpatient infusions. They do antibiotics, blood products, drug therapies, monoclonal antibodies, IV hydration, IVIG. They also do therapeutic phlebotomies. An exciting thing happening in the works for this is there's talks of a new infusion area being built. So this will be great. We will increase the number of chairs, be able to provide services for our patients, and so more to come on that. So that's very exciting. Interventional radiology procedures. So they do a lot down there. They assist the radiologists and technologists. They provide moderate sedation when it's appropriate for procedures, portacath insertions, dialysis catheter insertions, biopsies, embolizations, angiogram stent and insertions, paracentesis, thoracentesis, and I'm sure there is more that they also do there.
Big words.
Yes, all those big words. They also insert IVs for any of the patients coming in for CT scans. They make sure they're drinking their stuff. A lot of collaboration with Nuke Med. So it's a busy little area down there. So I think when the infusion area is able to move out of there, I think there's a lot of opportunity, and it'll be great for the patients as well as the staff. This is where our vascular access team lives, so our VAT nurses. So they do the insertion and management of midline and peripherally inserted central catheters, ultrasound blood draws, and ultrasound guided IVs. I feel like those have really increased over, I'm seeing a higher volume in people who are needing the IV, ultrasound guided IV access. So that is a growing area, which is great. And then the last thing is the epidural steroid injections and radiofrequency denervations. This is done by Drs. Mirko and Dr. Kanosh every other Monday and every Tuesday, Wednesday, Thursday from 12 to 5.
Love it.
Yes, that was a lot. Moving on, Foley Cancer Center. So the Foley Cancer Center, we are open Monday through Friday, 8 to 4:30. Some of our services that we provide there, we have medical oncology, radiation oncology, complementary services, research and genetic testing, and also women's health. So medical oncology, Dr. Eisman, he's a hematologist as well as a medical oncologist, so not all of our patients have cancer. We see people with clots, anemia. We have a very high volume of people with iron deficiency. We also do therapeutic phlebotomies over there. We run the clinic, I may have already said this, 8 to 4:30. But in our little area, most people don't realize we also have our own pharmacy. So all of our meds are mixed and then given right there. Alan is a fantastic pharmacist who's there on a daily basis, so he gets to know the patients and knows their treatments, which is great. Immunotherapy is given there. a lot of port access, drawing bloods, given injections. It is a nurse-run clinic, so not every day the patients see the doctors. They come in, they have a nurse assessment, get their treatment, and then go home. Some things we've done in the medical oncology world is that we have revamped some of our teaching. New immunotherapy teaching is being provided to patients. Radiation oncology, as we all know, Dr. Lovett served RMC for 32 years. He has retired. We have a new radiation oncologist who has started, Dr. Betka. He came from Saratoga. He is a great addition to our team as he continues to get his feet wet. I think once he gets a little bit more settled, there's going to be a lot of things coming within radiation oncology. He has slowly started to treat some patients for arthritis with radiation, so that is new and exciting. We also have hired an MA to our clinic, which is new for us, so she is working closely with Dr. Betka. Complementary services, so we have a new social worker in our department, Kelly Giancola, who has been a great addition. She is really getting back to the support groups, the women to women, men to men, building a bridge, a connection with them. She does a lot of work with grants and helping people get transportation. What else? Another complementary service, acupuncture. So we have an acupuncturist on site 2 days a week that helps with symptom management free of charge to our patients. So that is a great resource that we have there. And then, let's see, research and genetic testing. So we have a 0.5 research nurse on site. She follows up on trials. And I know Dr. Betka, with time, would like to start some new trials on the radiation end of things. So genetic testing, we are a site where UVM can send their patients and they can do a consult with them through telehealth, and then we help coordinate any genetic testing that needs to take place with them. And we also have started using some new blood and tissue send-out tests, and they are, depending on the test, depending on the disease, we have one that's a residual disease testing. So in these cases, it's when we think we have gotten all the cancer, but we want to be sure. So we do some blood tests, and it can detect any residual disease within the bloodstream. And then we have another one that does some gene sequencing for advanced cancers. It can detect mutations and help identify if there's any targeted therapies that would help benefit their treatment. And then women's health, Dr. Everett from UVM comes down the second Friday of every month and sees patients in our clinic. That prevents patients from having to drive up to UVM. So that's another great service we have there.
Awesome.
Yeah.
Thank you.
Good?
So much.
Yeah, thank you.
Little round of applause there. Good. All right, Tammy. Here we go. I don't think Faith was able to join us today, but we're very thankful that you're here, and we can't wait to learn more about
I thought I'd be able to look here and see, but I'm Tammy. I am the clinic nurse supervisor. I have been at Westridge since we opened in November of 2013, with the exception of a couple of months in 2015. So we are a multidisciplinary team. We provide services to patients with a primary diagnosis of opioid use disorder. We are open, I get there about 5:30. We dose between 6 and 10 every day. Medication administration, individual group, and group therapy. Pre-COVID, we ran probably about 60 to 80 groups a month with our patients. We are slowly getting back, we probably about 2 or 3 a month at this point. Education and case management. We have lab testing for illicit substances, and nurses support referrals, cardiology, and infectious disease. So right now we have 380 patients. Patients testing negative. We have 82% of our patients are negative for opiates. We are seeing an increased amount with fentanyl and xylazine, which I don't know if you guys know what the xylazine is. It's the horse and cattle tranquilizer, and it's awful. So let's see. Hybrid documentation. We are finally getting a new EMR. We are about 85 to 90% on paper, and we've been that way since 2013. So we're very excited to have the new EMR. And we are NCQA certified, and we're working on our 4th year of recognition for that. So for us to be able to do that with all being on paper, we have an amazing team. We are recruiting. We have several openings. So nursing, behavioral. I know. And 2 behavioral health clinicians, medical assistants, and safety officers.
Fantastic. Thank you so much.
Thank you.
Appreciate it. All right. Medical group operations. They have a whole crew.
We're here, all 3 of us.
Oh, I love it. I love it.
And we have a lot to talk about in 5 minutes, so we're gonna
do an abbreviated version, you guys. Okay? So,
You want to introduce yourself real quick?
Yeah.
What was the question?
so I'm Beth Knight,
I got it all sweaty.
director. We'll get into the areas that we oversee.
My name's Elizabeth Cahill. A lot of familiar faces out there, so it's nice to see you. I am a nurse, and I'm a senior director of the outpatient clinics.
I'm Chris Centerwood. I'm a director of the outpatient clinics. I've been with the clinic side of things for about 14 years.
All right.
We are the directors of the medical group. So the medical group consists of 23 outpatient clinics. It's approximately 300 or so team members that comprise all of the clinics. We do a ton of different services, both inpatient, outpatient. We're not going to get into all of the detailed procedures and services that we provide at all the clinics, but we're happy to dive into any of the services. If any of you want to reach out to any of us individually, we'll just touch on a few of them. On average, we see 100,000 visits a year across the 23 clinics. So that gives you an idea. I'm the director over Marble Valley Urology. That's a cute little kidney stone with little stones popping out of its sac. It's kind of cool.
We tried to come up with fun pictures for our slideshow.
So we do a lot of in-office procedures there. Kind of a cool thing. We do a lot of nurse-specific visits. So we do immunotherapy installations into the bladder. That's a nurse visit there at urology. Prostate biopsies, cystoscopies, a ton of procedures there, bladder fulgurations. And then I also oversee employee health. The employee health clinic is everything. We take care of all of our employees, new staff visits. If you're sick, if you're hurt, injured, we take part in all sorts of committees, workplace violence, lots of radars, so we're involved in all of those different committees. And then as far as I go, the endoscopy unit is not part of the medical group, but I am the director over the endoscopy unit. So it's a nice little collaboration and link to Krista, who manages and is the director over digestive services, general surgery, and pulmonary, which feed the endoscopy unit. So that's my skill.
So, as Beth mentioned, I have digestive services within my scope, and at digestive, I got my papers out of order. We have several skilled nursing staff that help support and manage the chronic nature of our patient population. Our RNs provide vaccines and education for our patients, and we have schedule for the endoscopy unit. Our non-clinical staff does, and I think that we have over 3,500 endoscopies a year, so that's a lot of scheduling.
Yeah.
I have the behavioral health clinic, which provides psychotherapy and medication management. We have some APRN and PA support for the med management. Important to behavioral health, which many of you may know, we collaborate with the with KGA on our employee assistance program, and we've also done many RMC team debriefings. So I'm sure many of you have had the opportunity to work with our team on that, and they do a great job with that. Pulmonary, as mentioned, that's part of the bigger collaboration on 3 North. Many of us know us as 3 North. We have pulmonary, we have kidney, and we have infectious disease. Pulmonary, we see patients. We do a lot of care coordination. We have several respiratory therapists that offer services to our patients. We do pulmonary function test. We do lung cancer screening. I'm looking at Jill. We do. I'm gonna look at my notes. We do pulmonary rehab. So a lot of services there, pulmonary wellness. And then kidney, we have 2 providers that come from UVM that are contracted that see our patient population there. And we also, they also provide support for the satellite dialysis unit on 3rd floor as well. And the ID services, we still have Dr. Singh that comes down from UVM to see HIV patients once a month. So we support her. And as many of you know, our ID services, Dr. Crowder has left the organization, but our teams are working to investigate what kind of support is needed for ID. And I suspect we will have a full detail on what that will look like very soon from our leadership group. Have the sleep clinic, eye care, neurology. I'll try to speed up.
5 minutes is closing.
I know. We have general surgery and our wound care team. Our surgeons, we have a beautiful procedure room which our nurses are able to assist in. At our general surgery clinic, we perform lipomas, excisions, sebaceous cyst, radiofrequency ablations, breast biopsies, temporal artery biopsies. And then our wound care nurses see patients obviously in the outpatient setting, and those same nurses see patients on the inpatient side, so there's a great continuity of care. Many patients have given us great feedback, really happy to see the same nurses that they saw inpatient, so that's been really beneficial. And then one thing you may not know is we have a group of professional coders that are under our medical group, and there's 9 of them. Many of them work remotely, 75% of them. And fun facts for them, there are 11,000 encounters per month that they review and release charges on for our medical group. And on average, those charges per month are about $4 million. That's not what we get reimbursed for, but that is what the volume is of going out. Per month, yeah.
Great.
Take it away.
Okay. All right, so I'm going to talk to you about the clinics that I specifically oversee, but as you can tell, we're a group. So we have the 3 of us as directors, and then we have a group of managers and supervisors that work with us as well. Some are out here today. And we also intertwine with many of your departments, right? So we kind of work with the OR, we work with the wound care. We also have our heart center, which is we see cardiology patients in the outpatient setting, and then our physicians, you guys work with them when they come to the inpatient side. And they also provide echocardiography, so like all of our echo techs, those are housed at the clinic, but they come to the inpatient side. We're all one big team that service the inpatient and outpatient. At the clinic itself, we also have nuclear testing, and we do stress testing, as well as echoes there. And then we have the cardiac rehab unit, which is housed over at the main campus, but all of our nurses do all of the jobs. So they go back and forth between all of those different areas, and they're involved in our testing center as well. ENT and audiology, we have that service, which is, so you have ENT services which are doing procedures, as well as services of evaluation management. They come to the OR and they perform surgeries there. And we have 1 surgeon right now. We're trying to recruit another surgeon. We have 3 PAs or nurse practitioners, and then we have 3 audiologists. The audiologists are doing diagnostic services as well as selling hearing aids to people that may need them. So if you know anyone who needs hearing aids, please come and see us. We will provide a full diagnostic evaluation of the patient. We don't just provide them with hearing aids, but we actually do a full diagnostic experience for them. And we will fit you to a hearing aid that works well. Vermont Orthopedic Clinic, that's another one of ours. So that's a really big clinic over in the MOB. And we also have a sports medicine kind of section of Vermont Orthopedic, so we will provide sports medicine services. You may have had those services yourself or known a child maybe in the sports arena that got injured, and we will see them the next day and look at their bones and look at their bruises and make sure they're safe to get back to the field or the court or whatever they're doing. And we also have a Killington Mountain Clinic, which is actually an urgent care clinic, which people aren't really aware of that, but it's an urgent care clinic designated and accredited for that. It's open from Thanksgiving to Easter. We do close it when the mountain is closed because our business is mostly around people from out of town or our local people that are skiing on the mountain. And then our physical medicine and rehab, spine and pain management clinic is all encompassed underneath the Vermont Orthopedic. So that's just as it says, it's physical medicine, it's pain management, and spine care. We have a women's healthcare clinic as well, which, we have some exciting things happening there. For the first time ever in the history of Rutland Regional Medical Center, we are hiring nurse midwives. So that's exciting. We actually have hired our first one. Her name is Sarah Barton, and she'll be starting in April. There is a baby expo that Leah will be at with her crew on Saturday, and she will be there. So if anyone wants to stop in and see her, you certainly can do that. We're excited about that. Our OBGYN physician group will be changing from a 5-physician group to a 4-physician group with the addition of the certified nurse midwives. We think that brings a nice holistic group of providers that can provide care for our community. It's something we've been asking for a long time as community members, and we're going to finally get it. So we're excited about that. And then the endocrinology clinic, we do diabetes, and we also do endocrinology full services that you may need there. We have 3 physicians and a nurse practitioner who will be starting there soon. Oh, sorry, physician assistant. Last but not least is our specialty clinic, which is down in Dorset. That's a little satellite clinic that we have to provide services for people in that area because there aren't a lot of specialty services there. So currently we have ENT and audiology, orthopedic, and women's health down there. And that's it. If you have any questions about our services, let us know.
Great. All right, I think we have up next is going to hear from Shared Governance. I promise we're going to close people to our Q&A session. We're going to hear from our Shared Governance team, and then we'll hear from Gert, and then we'll open it up for questions. Okay? Take it away, ladies.
Oh, I don't know how to use this thing. I'm sorry.
Okay, here, I'll take it.
I only have 2 slides.
I'm now a professional.
So, for everyone that doesn't know me, my name is Carrie Bullock. I started here in 2011. I'm the current president of Nursing Shared Governance, and this is my 6th year in Nursing Shared Governance. I started out on the medical oncology unit as a staff nurse, went to the float pool, and now currently work in utilization management.
I'm Yulia Smith. I have been here, I think, going on my 7th year. I also started on 5th, then went to the float pool, and now I'm in case management. And I'm currently vice president, and I think this is my 4th year in shared governance.
And we also have one more cohort, Danielle Gray. She is a case manager in the hospital and has been here about 15 years, but she was unable to make it today. So our Shared Governance Council, we meet to discuss policies and processes with a goal of improving patient outcomes. We follow the magnet model, and Nursing Shared Governance really helps give nurses a voice, empowering staff to work from all different departments all together to find solutions, and our goal is to deliver the most exceptional patient care that we can provide. We currently meet the second Wednesday of every month from 8:30 to 12:30. With COVID kind of put a damper on our council, we went to Teams only meeting during that time, which was really just difficult for us. We couldn't get the participation or the involvement that we wanted during that time. So we're trying to revamp the program this year. We're looking for more members, so if leaders or any nurses are interested in joining shared governments, we would love to have you. Even if you want to just come in and sit on one of our meetings to see if it's something that you would like to do, we would love to have you. Just hoping to create an environment that promotes professional growth and development, shared decision making between nursing bodies, and accountability for patient care and outcomes, and hope to support a commitment to lifelong learning in nursing.
Love it.
That's all we got.
That's about it. We need more members.
Quick.
Now that's an efficient presentation right there. I do strongly encourage our nursing body to get involved with shared governance if you're not already. And I know Elizabeth and I were talking, was just a couple weeks ago. She has some really great ideas for how we might be able to engage our outpatient folks too, whether it's a subcommittee or part of the overall committee. And I know Gert's working with the team as well. And Leah also has been providing some support. But great job, you guys. Looking forward to seeing all those great things. Okay, so we'll wrap it up here, right? Yes. With Gert Mays, again, our new manager for nursing excellence, and I'll let you take it away. And then we'll do some Q&A.
All right, guys. I think most of you know me. Can you hear me okay? I've been telling everybody to project, and I'm the one who needs to do that. I've been here since 2007. I've been a lifelong OR nurse, but after all those years, I've been feeling the urge to grow and develop, and I've been focusing on helping promote professionalism and evidence-based practice and getting people out there with their professional organizations, and so I made the jump. So, sorry, Deb. But it's really been a positive experience, and I can't say thank you enough for allowing me to do this. So, with nursing excellence, where we're going, magnet is the biggest thing. That is one of the first things that I thought of with this position. We got our magnet designation in 2020, and it's time to bring this back to the forefront of everybody's minds. And honestly, it should never be in the back seat. It should always be in the forefront of our mind. And that's one of my goals, is to make sure it's out there every day. Everybody's aware of, you know what, everything that has already been talked about and even more is magnet evidence criteria. So part of my job is to collect that data and then get it down, documented, so that we can then submit our evidence at the end of 2024. You think that that's a long ways off? Well, it's not really. So right now, I've already started making notes about different criteria that could represent the different pieces of evidence. And you're going to see me going around asking for ideas. What are your thoughts? What are some projects or processes that you've been involved with as a team member, as a staff level, at leader level, that would reflect that criteria, so that we can have that in our back pocket and we can start writing to it. And then that way, when it comes time to submit our evidence, it's there, we've got it, we can just push it forward. And then also, by asking those questions consistently, it brings it to the forefront of everybody's mind so that they recognize, yes, we're not just putting this all down to receive a credential, but it truly is reflective of what we're doing here, and I truly believe that. So it's out there, just need to find that. So you can see here the timeline. We are ready with Wendy Klein's help. In December, she submitted the interim monitoring report, which was great. And now the next thing that's due is at the end of this year, we have to submit our application to be redesignated, and then in October of 2024, that's when our evidence is due. So that's the timeline that we're all working on. All right. The Clinical Advancement Program is another project that really piqued my interest over the years, and was sitting in on some of the shared governance meetings over the past few months. And then listening to the projects, we were like, oh wow, this is an opportunity here to really reinvigorate our CAP program. I think quite a few of us were like, how do we help support people who wanted to apply for CAP? And we looked for the information, we found a little bit, but there wasn't a lot out there. So okay, let's take a look at it. And so what's happened is that we're developing some very concrete instructions for how to apply for CAP, from the time that somebody is starting to think about it to then, okay, you're thinking about it, now the next step is go to your leader, talk about it. You have an idea for a project, talk to your leader about that. They get the support, they give you the support. Okay, now then the next step. So all of that is going to be fully outlined. And then when it comes to identifying which level of CAP that you want to apply for, we have that grid still with the level 1, 2, 3, 4, 4A and all of that. But then we've also got a table that outlines those pieces of evidence, and it's categorized under the magnet criteria. Use that as part of our magnet evidence, right? Because that is what it reflects. But then also giving examples of what that criteria is. And now you also have to provide the evidence that you did that, not just checking off a box, but where can we find this information, so that then when it's time to write to this magnet evidence, which all of these CAP applications are, we can go find it and use that. So it's really a cyclic project. So that's where we're at. It's going to be on the nursing SharePoint site. The current model is still there. We'll just replace it with the revised version. Nothing brand new, but you can see the location of it is on the nursing SharePoint site. You just go to nursing, and then you scroll down, and then there is the icon for the clinical advancement program. You click on that, and then it will open it up. There's the instructions, there's templates for the poster, there's the clarifying evidence. We'll have a mentor list. We're going to reinvigorate our mentor group. So we're looking for mentors. Anybody out there who has been a mentor in the past or applied for CAP a couple of times, you're more than welcome to reach out and say, hey, I'd like to be a mentor, and we'll provide the education on what it takes to do that. So that's where we're at. That's it.
Thank you, Gert. Thank you. All right, guys, so that wraps it up for us. I do have to, really quick before we get into Q&A, I have to thank Maria Cruz, the amazing executive assistant. She is just, she really helped pull this all together, as did Gert. Thank you so much. And thank you to all of the people who accidentally wandered into my office while I was in the middle of putting some of these slides together and then held you hostage while I practiced some of what I was going to say. I appreciate it, and I'm sorry. Thanks to everybody who put slides together today. Again, we're really trying to get these back up and running on a routine basis, and we really want to make it about the whole organization, the whole body of our nursing body here at Rutland Regional. So I appreciate our outpatient partners. Hopefully in future forums, if this was a format that we liked, we'll start hearing from some of the other areas so we can really start to learn about our nurses across the entire organization and again, understand what it is that they do so that we can all work together in a really effective way. Very excited about our bright future. And yes, thanks again. I know standing up and talking in front of people isn't necessarily everybody's favorite thing to do. It takes a lot of courage. So I appreciate everybody for taking the time to do that. All right, so we will go ahead and open up for Q&A. I know we're short on time, so quick reminder that you will get an electronic form. So you just keep those questions coming if you have them, and we'll be sure to get back to everybody. Very, very committed to getting back to people. So just wanted to make sure that was clear. All right. Yes.
What I was wondering is, on those numbers you gave us, their inpatient days were up slightly. Do those inpatient days include the level 2s?
Inpatient days. Are we talking about
those first slides you showed?
Yeah.
The dashboard.
Let me make sure I know what we're talking about.
It was the inpatient days.
On access to care on the scorecard.
Yeah.
I would check that. So you're saying you think that the dates are off?
No, I just was wondering, are they included in it or not? Because
Oh, they are. Yes,
They are. Okay,
I believe
that's
they
what-
are. Mhm.
Okay, 'cause
Sorry,
it's-
I misunderstood you. I thought you were saying that they were off.
No, I'm just was wondering if they were included since there's so many that are here so long.
They are. Yes.
Okay.
Mm-hmm. Oh, does it now have a mind of its own because I clicked too many times?
Because you open your cooking.
Sorry. I take back what I said about being a pro at the clicker. Any other questions? I saw hands. No? Yes.
Is there a place to find like a list of committees and a point of contact for them? Because I can't remember.
Good question. Maria's nodding her head at me.
So that question actually has come up, and I have not been able to find a like master list anywhere.
Yeah.
It kind of
Okay.
feels like you have to know somebody to ask. Like I don't.
This is true.
I'm just in DI. I don't see anybody else.
So I appreciate that, and I think it's a really important question, actually. For those that are tuned in, the question was whether or not we have a list of committees and who's responsible for them so that we can connect with them if we're interested. The answer is not yet. That is some of the work that the quality team is working toward. They're working in collaboration with our compliance and risk management team so that we can really get a better understanding not just of our data, like we were talking about, but also of our committees and those structures. So very, very important question, and that information will be coming. But in the meantime, reach out to your leader if you want to learn more, or you're more than welcome to send your leader or myself an email directly, and I can try to get that information to you a little bit more quickly.
Even if it's just like a little link on SharePoint, here's the list, here's the person to contact. I feel like that would be.
Great suggestion. I am totally on the same page as you.
We also need a DI nurse in nursing care governance, just to put
Okay.
that out there.
Oh yeah.
That was an amazing plug. Other questions?
Okay.
Other questions? Comments? Feedback? Anybody have a great story that they want to share so we could maybe end on a really happy note? Okay, note to self. I won't ask that question next time.
No, ask it in the beginning of the meeting so we have time to prepare for it.
There you go. No, I really am excited about the direction that we're headed. I think we have an absolutely fantastic group of not just nurses, but really of employees in this organization that are truly committed to we're committed to excellence. We're committed to making it better. We want to learn about where we have gaps. We want people to be part of the solution. I can't stress enough how much I hope people get engaged. We will work on that list so that we make it easier for you to get engaged. But really want to make sure that people feel like their voice is heard and that we're in this together. Yes?
I do have a positive story. So today, just quickly, today I was rounding in the emergency department for Falls. Everybody was busy because they had a very busy day, and this was at 10 o'clock, and so I said I don't have any problem rounding by myself. I'm a nurse, I can go into the room and talk with the patient, and I don't know what is going on with their care. Anyway, so I did see 3 different patients, all of who hadn't been seen yet. They were triaged but not seen. They were all fall risks, and I was able to, who knows, maybe even prevent a fall. But through it, was able to help calm all 3 of the patients down by having them focus on the smiley face on the board and just do some deep breathing and know that we're taking good care of them and that they're safe and they're in the right place.
It's fantastic. Thank you so much. I love that story. Thank you. I'm sure that they also appreciated it. And thank you for rounding. All right, guys. Well, if there are no other questions, I sincerely thank you for joining us today. Again, this was kind of our first one in a long time, so we'll try to work on some things like timing and making sure that we get communication out ahead of time. I really, really encourage you to fill out those electronic discussion evaluation forms. We purposely are doing it electronic, not just because we want to be environmentally conscious, but also because it's a better way for us to track and be able to get back to people and track that we've done that. Hence us not having paper for it. All right, well, thank you all so much.
Thank you.